Okay, let's talk about this really cool case of an anterior cruciate ligament tear. This was a 21-year-old male football player who says his knee buckled at practice the day before. He came down after catching a ball and felt a pop. Nobody hit him, and he could not get up after he went down to the ground. He denies any numbness, tingling, or that the pain is radiating up or down his leg at all. He says it's swollen and he can't really bend it, and he's having trouble walking. And his athletic trainer has him using ice, compression, and ibuprofen. On exam, he looks healthy and normal except his knee is an obvious effusion, which you can see in this picture on the right. Here's his effusion. Wrong knee, obviously not our patient, held in about 20 degrees of flexion and he has trouble extending it. Range of motion is deferred, strength of flexion and extension are intact. And then when you do a structural exam, is a positive Lockman's test, an equivocal anterior drawer test, a negative posterior drawer test, and a negative varus and valgus test. His dorsalis pedis pulse is normal. Let's talk about ACL tears. This is the number one injured knee ligament, up to 2/3 of knee injuries in certain sports. It's generally a non-contact injury, meaning nobody actually touches the athlete. It happens from a sudden deceleration, pivot, change in direction, or awkward landing. And then inside the joint, you have rotation, valgus stress, and anterior tibial translation relative to the femur. Let's talk about the ACL anatomy. On the tibial side, it inserts onto the anteromedial tibial plateau and originates on the femur from the posteromedial side on the lateral femoral condyle. It's made up mostly of type 1 collagen. Most ACLs are double bundle, which each bundle has a slightly different function. However, some people have a single bundle or other anomalous insertions that are congenital. And we can see this illustrated here on the right. Here's the tibial insertion on the tibial plateau, and you can see the ACL tracking backwards to the lateral femoral condyle here, and it's on the medial aspect of that. And the function of the ACL is to stabilize the knee, prevent forward translation of the tibia relative to the femur, maintain rotational stability under varus and valgus stress. There are a lot of injuries associated with ACL tears, about 3/4 of cases. Most commonly, that's going to be the medial meniscus, but it can also be the lateral meniscus. You have osteochondral defects, which is a bone cartilage kind of fracture type injury. You can have more than one ligament injured, which can include the PCL, LCL, and MCL in the posterolateral corner. And then this illustration shows what's the so-called unhappy triad of the knee, which is sort of controversial, but essentially you have a torn ACL, a torn medial meniscus, and a torn medial collateral ligament. So you'll see that in the literature sometimes. Risk factors, it's much more common in women. Certain sports like football, lacrosse, soccer, basketball. There's anatomic predictors. Some of those are congenital, some like obesity or not. And then there's some female risk factors which have been identified, which is dynamic valgus positioning, leg dominance, ligament dominance, and truncal control. Even though we think our athlete has an ACL tear, we also have to consider other stuff, right? So meniscus, LCL, MCL, and PCL. There's something called the posterolateral corner, which is sort of a structure or combination of structures in the posterior lateral knee. Osteochondral defect we mentioned. Sometimes it's actually a patellar dislocation when they feel that pop. In a skeletally immature athlete, you can have physeal fractures, multiple ligaments, and then a bone contusion. Best case scenario is a bone contusion because it's not really a structural problem. So patients are going to describe a sudden directional change, stop, or abnormal landing. Almost universally, they describe some type of pop, followed by buckling, pain, and swelling, loss of range of motion and trouble walking, and instability. On physical exam, they're going to have an obvious effusion, right? They're bleeding into their joint. The only time they wouldn't is if this was an old or subacute injury. Sometimes the body has reabsorbed most of that hemarthrosis. They're going to have trouble walking, trouble extending the knee, and then they're going to have a bunch of special tests, which are usually positive, including most commonly the anterior drawer test, which is pictured here, Lockman's pivot shift, which patients do not like, the lever sign, and forced active buckling test. Usually you start with radiographs, which are typically normal. You can see something called a Sagun fracture, which is illustrated here. On the lateral knee, you get a lateral tibial plateau avulsion fracture. You also have a tibial spine fracture, which is more commonly seen in pediatric ACL injuries. MRI is, of course, the gold standard. It has a great evaluation of the ACL and the other soft tissue structures in the knee, and then can give you some secondary clues like bone marrow edema, joint effusion, etc. Ultrasound is validated as a modality to examine the ACL, but not commonly used. Non-operative management is rare and basically limited to patients who are poor surgical candidates, who don't walk, who are demented, that kind of stuff. In those cases, you can do PT, activity modification, and brace depending on how cooperative the patient is. Otherwise, the gold standard is surgical intervention. There's a bunch of techniques, right? Mostly you're reconstructing an ACL with something else, and that's going to include a hamstring graft, bone patellar bone, quadriceps tendon, among other donor sites. And then often now there's doing PRP and other orthobiologics perioperatively. Let's talk about our patient. Basically, he had his MRI, it shows an ACL tear, and here the ACL is just absent. There's nothing where the ACL should be here. Okay. He had surgery, which includes reconstruction of using a hamstring autograft and some PRP. He was in a hinged knee brace postoperatively and started rehab the day after his surgery. That was mostly working on mobility and recovering some of his quad strength. And the following 3 to 6 weeks, he really worked on range of motion and functional activities. At 6 weeks, he is weight bearing with a goal to return to sports and play football next season. So, three key points about ACL tears. The first is they are typically non contact injuries from sudden stops or change in direction, and common in sports like soccer, basketball, and skiing. Patients usually hear a popping sound, immediate swelling, pain, and knee instability, and have some classic clinical findings. Diagnosis is confirmed on MRI, and the vast majority of patients require ACL reconstruction.